Maxillary diastema closure, first of all, it has been defined as a 0.5 millim and by Dr. Keene in 1936, because such a space will be, such a gap will be noticeable, but usually in our practice, we may face even a little less than this space, and the patient just want to close it because he's annoying of it. So this is a general definition, but it can be expanded. And some studies have found that in the mixed dentition, when the so-called the ugly duckling stage, we have a diastema by the it's a normal physical process. When we central incisor erupted and we are trying to waiting the canine to erupt, but they found that a space of 2 millimeter in the mixed dentition is unlikely to close and may persist as a diastema, median maxillary diastema in the permanent dentition. So we should pay attention from an early stage and to avoid this problem. Why we choose the direct technique? Because it is the most simplest technique. It is a fastest technique. We complete in one session, and of course less expensive in comparing it with the indirect technique, the veneers or crowns, or even ortho. More conservative. We need no preparation and no tooth mobility, which may expose the tooth for more maybe non-vital, become non-vital and crosses, or maybe face a root resorption. More predictable, simple procedure, and can be learned and predictable, and also a color match. We will see that color match in diastema is not that big issue. I will explain it later. And criteria has been done in 2005 by Dr. Wallheit that successful diastema closure have some criteria, in which can be summarized in the emergence profile with a natural contour and no black triangle and a smooth subgingival surface or margin that does not catch or shred the dental floss. And to accompany and take an unperiapical radiograph to see the smoothness and the absence of the undercut in this area. But the floss also can do this purpose. But everything have a limitation, and our limitation here with the direct way is the size first. A size of, we are limited to a size of 2 and 2.5 millim and less. Larger than that, we can see in this case more than 4 millim. This is for Dr. Osama Shalan from Palestine. Great greeting for him. And a case like that, maybe we can shift to another treatment or combine multiple strategies in one case. For example, in this case, he did fixed on ortho. He moved the two sensories to each other to share this space with other teeth between the central and the lateral. So the case became a multiple diastema, and he treated also with
Dr. Sadeer, can you hear me? Okay. Dr. Sadeer? Dr. Sadeer, can you hear us? I think his video stopped for a second. All right. Stay with us for a few seconds while we restart the image. Give us a few minutes. These technical issues, they are bound to occur time to time when you're dealing with the online forum. So in the meantime, if you have any questions or anything, just write us down underneath. I want to give a shout out for a few more people that joined us. Hello, Marco Torres from Mexico. Hello, Rosanna from Qatar.
Everything that
Hello? Can you hear us, Dr. Sadeer?
Yes, I can hear you. I'm sorry, I have some interruption with the internet connection, I'm afraid.
Don't worry, Sadeer. Take your time.
Just
Okay, I will continue.
restart it again, and then we'll play it.
Okay, I will continue. 1 second.
So Amra from Bosnia and Herzegovina. We have so many people joining us today. It's wonderful. It's, to be honest, it's an experience once in a lifetime. When you go to a lecture room, you will never find, I think the biggest lecture room I've been is about a couple of hundreds of people, but having around thousands of people watching you in an online live stream, it's great.
It's amazing because since we started, Bear done the eyelid online congress, and then we've done the congress with the Saudi Dental Society, and now this is the proudest moment when we have a symposium run by our graduates, our ambassadors, each of them presenting his or her clinical cases. And it's really nice to see a mix of ladies and gentlemen, and younger, very young, and also a bit older. So it's really nice to see mixture of all. So I think Sadeer is back.
Yeah,
Okay.
you can play it again.
I'm sorry for the interruption.
Don't worry. Go ahead.
Okay, continue. We were talking about the size, and I said that the size is an issue because we are limiting some millimeter. And about the formula, we said he combines several methods to treat a case like this. Another limitation is the oral hygiene. I think we should maintain the patient oral hygiene before, because if he cannot maintain his own teeth, if we are added any tooth or any composite material or any additive dentistry, he will also face a problem in probably clean it. And the skills, of course, everything needs skills in our field. A common mistake we are facing in this case are the asymmetry, in which we have one tooth become larger or wider than the other one, and we are facing it when we're trying to close the diastma together in one way, especially when we are using the posterior matrix, because of the convexity we cannot say the midline between the teeth. Secondly, we are talking about ledge. You can obviously see this case, how much ledge he created, and it will become very hard for the patient to clean, and it will compromise his periodontal health. Color mismatch is not a problem, really not a problem in the diastma closure, because we are adding a composite in a symmetrical way in the two centrals. So if we are adding some whitish material on the right and we adding it to the left, there will be an illusion, and we will not see probably the differences in the color. And also, it's a common problem that's happened when we are closing or we choosing the color after placing the rubber dam, because the tooth gets more dehydrated and increase the value and become more whitish, and we will absolutely choose the wrong one. Golden proportion, another mistake is sacrificing the golden proportion. And when we talk about the golden proportion, so there's a rule, when the closing a diastema, if the tooth length is greater or is changed, so we are in the golden proportion. For example, if we had a diastema on the tooth and we are a percentage of 80, we know that the golden proportion percentage between 75 and 85. In a length of 10 and width of 8, we have an 80%. If we are trying to close this diastema and increasing the width, the height of the tooth from the incisal edge, or from the we can also increase it from the gingival part. If we have, for example, we have an overrupted gingiva. So if we increase the length of the tooth along with the width, closing the diastema, we are in the golden proportion. But if we just increase the width, and for example, we are getting in a 90, for this case, 90%, so it is more above the golden proportion. But again, it's remain the patient view also. We need to talk about aesthetic sometimes more than cosmetic. We know that cosmetic are our dentist parameter, and aesthetic is the patient personal perception about things being beautiful. You may think this width in the 90% is good for him, so it's good also for us. Also, in this case, for example, we have previously closed diastema. You can see how much stain on the tooth, how much inflamed tissue, and how much sacrificing there is in the golden proportion. It's above 110 maybe. So first of all, I refer the case to the periodontist. He did some slight gingivectomy, increasing the length of the tooth. And after sessions, we can see that the patient cannot also maintain his oral hygiene. Maybe you can see that the laterals are better than the centrals, even the midline of the centrals, because of the presence of this material, the composite, and it did not polished wall, so it always track stains and calculus, and it's always being difficult for the patient to clean. So it may be not the patient problem, it's also our problem. So after maintaining it, we place our rubber dam and remove the all composite and continue with our work, which I will explain later. We did our emergency profile and increasing the length of the tooth, and we may get some good and acceptable look and golden proportion. And you can see it is, I think it's somehow wide, but the patient say, okay, so it is okay. Another mistake is the black triangle. Black triangle, normally, how can we close the diastema? This is the gingival line, and this is after closing the diastema. We are forcing composite by several means under the gum and under the gingiva, and this composite act as compress the gingiva, which will act as a balloon. The gingiva and the papilla in this area, when it's compressed from one side, it will expand from the other side and get stimulated if there is a contact. So after we adding this part of our process, the papilla will stimulate it and gets pressed, and it will continue its healing toward and closing that black triangle. The problem we faced, even if we did this, is the bone height. As a rule, as Dr. Tarnos said in 1992, we should have a minimal space between the contact point and the bone, about 4 to 5 mm. More than that, you can see in the chart, above 5 mm, if you have a 6 mm between the contact point and the bone, we will facing that black triangle will fall just to 56%. Even if more, 7, it's only a quarter of that black triangle will close. So this can be a guide for us to ensure that our black triangle will not exist, and it will be closed completely by the papilla. The problem in closing the diastema, and especially closing the black triangle, is we are converting the shape of the tooth from the most aesthetic and more favorable triangular shape into the square shape, and move our contact point from the incisal edge of the two centrals into the more cervical part, which give us more ugly appearance and unaesthetic, maybe unaesthetic appearance. For example, in a case like that, I faced a small black triangle and incisal wear or incisal fracture. After restoring it, you can see, and I did not add much in I changed the transitional line and restoring the fracture, but I did not added that much of composite in the black triangle and closing it completely, because it will be unaesthetic. And this is after a follow-up, you can see it is enough. The papilla just simulated, and by the act of composite, subgingivally highly polished composite, and it's all done. I think we should pay attention more to this part, not adding more than we need of composite, because of course we'll close it, but this is not what we want. We can be ensured, this is a way which called the bone sounding. We can ensure that this black triangle will be closed by a bone sounding, but we can use a probe after anesthesia, of course, inserted in the proximal surface of the central, and we can just test the space or the distance from bone to our future contact point to be between 4 and 5 mm to ensure that black triangle will not be created. Treatment technique we have, in general, we have two treatment techniques. We have the Paul matrix technique and silicone index technique, and I would like more to specify it as a guided and unguided technique. First, we may not use a guide in the Paul matrix and sectional and other, and we may use a guide as a silicone index, which we made previously, and a mock-up and take the width of the tooth and something like that. So it will facilitate our work, but it's not mandatory. We can just do it freehand. Paul matrix technique. This is a case, the initial stage, and the patient have a diastema at about 2 mm. And the problem with this case is these anterior teeth are rotated medially, are not straight. And I referred it to the orthodontist, but he said that we have a high relapse rate in the cases like this. And we decided to close it by just by composite direct technique. And what I did here is I did isolation, itching, and I have to say is talk about something despite the time we have. As Dr. Abdulrahman said, we have an issue with the diastema or any anterior teeth in case of unprepared enamel, because unprepared enamel is covered by a layer, a shield, which called the prismatic layer. We all know that we itch enamel for 30 seconds and then 10 for 50 seconds, but this is not enough. At least in diastema closure, because we are facing unprepared intact enamel, we have to itch more, not less than 60 seconds to get a reasonable and somehow strong bone, because of the problem of this prismatic enamel, which have a parallel arrangement of the epithelial crystal with highly packing, and it's so difficult to be etched and treated. It is very controversial topics, because many studies have been done, and they also the width of this, they are very controversial. Some say it is just 5 micrometer, and some studies raise it to the 100 micrometer between deciduous and the permanent teeth. But as a general, they they found that we have between 60 and 45 micrometer of thickness of this layer. to 10 micrometer, and this is the area of the etched enamel. So we have not even passed the prismatic enamel. Also, you can see the prismless cone prism and type 1 prism etch cannot completely be removed using the deep acid, even using the deep acid etching. In this picture, I cannot know if you can see it properly. This is the intact enamel surface before etching, and this is after a 15-second etching, nothing happened. And this is 30 seconds, we can barely see the porosities of the So they move into another way, which is called the dynamic etching, by bringing fresh acid into the etching front surface. They just using a brush, they move the Victoria, I can see your face. Now we are limited time. Okay, I can hear you. Okay, the dynamic etching. They use the brush, just a brush. I don't know. Okay, I will continue despite I don't know what happened. The dynamic etching bring the fresh into the enamel and even make a better result. So after all, we think that the only way to get a perfect result is by acid etching, by grinding of the enamel. But grinding is not a perfect way to do it. So we are better results of bonding when we associated the air abrasion with the conventional, the sandblasting, which I mean. So we continue with our case. This is after bonding, and this is the pull matrix technique. We place this cellulose strip in this way, compress it palatally from the figure by our index, and create that emergency profile. After all, we continue the other parts, and we should use a vernier to measure the width of the tooth, and after that we will continue to the other tooth to ensure that we are not sacrificing the symmetry of our work, and we can get maybe good result. Even this case, this is a very small diastema, and this is a follow-up in the same technique and the same way, 6-month recall, and material of choice. We can use any brand, even with the flowable of the emergency profile. We can use any brand, and also we can use a packable, because recent studies said that the flowable composite did not add any value in the macro leakage and clinical performance over the packable one. Other modalities, of course, you have a BioClear with its different shape, and we have the newly introduced Unica, and also this is another case. I'm sorry about the time. I don't know. This is initial, and after trying the tribottom technique, I choose the shade of I2, more contrast to more clearly, and we can see the white and black to take our value. And after that, we can use maybe the polarized. You can see here important thing, the role of the rubber dam and the diastema closure. This is before and this is after, and you can see the height of the papilla, how much it reduced, which will facilitate our emergency profile. Etching and our adhesive protocol, and this is the final result. Not all diastema should be closed. The diastema in mixed dentition, as I said, there is a naturally space between the two centrals. We should just restore these teeth without closing this diastema. And even in case of multiple diastema, we can use our guide, the DSD, just to know where to edit or where to not editing in order to centralize our composite. And you can see how much we can see the difference in only editing a small parts of composite in a selective area using the DST and to centralize the midline of the tooth. And I'm sorry I got so fast with the technique on the last slide because of the limited time we have. Thank you all for paying attention, and that's all. So Victoria, is it good?
Amazing. Sadeer, this presentation was outstanding. I can tell you've put so much hard work into presenting the cases, into putting everything together. Really beautiful photography, honestly, perfect. I'm really sorry about the connection issues that we had, but it was all worth it looking at your presentation. So thank you so much.
Really. I hope. Thank you very much. I hope all participants heard me because I even don't see my face here. I don't know what happened. So I'm really sorry.
Don't worry.
Sadeer, beautiful, beautiful slides, beautiful, clear message. And this is, you know, what you've presented is basically the ethos of Baird Academy is like, in our courses, we try to put our clinicians, our younger colleagues on the right track and then encourage them to flourish and pursue their passion. And you've pursued your passion in cosmetic dentistry, in adhesive dentistry. And I guess your patients are very lucky patients because not only you're skillful, but you're also passionate. And that showed in your slides. Thank you, Sadeer, and regards to everyone in Baghdad, in Iraq. We're so proud of what you've done, my friend. Thank you for being part of this forum, and stay safe and keep well.